really an honor to have you with us. And it's hard to believe, but this project started on my desk as a regulator at the Department of Managed Healthcare, looking at quality improvement data for the state of California in 2006. And since that time, we've held approximately 309 gatherings. And we are just so pleased that the amazing experts that volunteer their time to be with us, and the collaboration that has built across the state of California. UC Berkeley is our mothership of the project right now within the Center for Health Outcomes and Innovation Research. We receive funding from the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the University of California, San Francisco provides volunteer time, as does Stanford School of Medicine and the California chapter of the ACC. We are also supported by the Stroke Awareness Foundation and the Tennisketter Family Foundation, the Duperow family, Johnson & Johnson, Amgen, Genentech, Novo Nordisk, Amarin, Boehringer Ingelheim, and the Health Trust of Santa Clara County. Next slide, please. Most of you know me, and I am just honored to facilitate these meetings among brilliant people who are good-hearted and bring their expertise as volunteers to spread best practices to improve clinical outcomes. I am driven to continue this work by the fact that my mother died of a stroke when I was 15, and if best practices were being followed, I don't think that would have happened. Next slide, please. So just to provide a little bit of context that I don't think the public really understands, it's important to recognize that already in the 35 to 44 decade, although we screen for various cancers on a regular basis, we don't do a good job on that with cardiovascular disease. So we will be adding to this slide diabetes, but I'll just emphasize that already in the 35 to 44 age group, compared to the two main cancers that we screen for women, breast cancer and cervical cancer, cardiovascular diseases, including heart attack, stroke, hypertension, already are killing more young women. And for men, it's 7 times more men are dying from cardiovascular disease already in that early decade where we're often seeing active parenting. So we want to really emphasize we need to get started earlier on the preventive work. Next slide, please. So one of our great heroes in this world of spreading best practices is our co-leader, Dr. Edward Yu, who brings wonderful knowledge and passion to this topic at the Palo Alto Medical Foundation, which is the flagship of the Sutter organization in Northern California. He is the Vice President and Chief Quality Officer of Palo Alto Medical Foundation. And I'm going to hand over the meeting to you now, Ed. Next slide, please. You're muted, Ed, so I'm very sorry. I was muted when I said that too. It's so easy to do. Thank you for reviewing how this data matters in our world of quality improvement.
Yes. Well, thank you, Hattie, and then welcome you all to this wonderful afternoon at the Right Care Initiative. So what you're seeing here is data pre-pandemic looking at 2 chronic conditions that contribute to strokes and heart attack, which is our purpose here, is to reduce those incidents. The top one is looking at diabetic control for our patients. This is data from the Integrated Healthcare Association looking at a commercial managed care population. And the screen and the gold bars on the bottom is blood pressure control for the same population in the pandemic year. And this has been the focus for our initiative over here, is to share and to learn and find ways to optimize the control of these conditions that we know are major drivers of bad outcomes that Hattie has just shared. And what we do here, next slide, please, is through this consortium here from multiple stakeholders, from patient groups to researchers to care implementation groups, is to share and learn the multiple evidence-based approach to optimize outcomes for this, starting from the patient activation engagement piece on the top, on looking at care teams, expanding the care teams to assist with management of these conditions, and most importantly, also to bring in evidence-based approaches to apply the known knowledge for this. A lot of the work that in groups like us do is how do we implement known evidence to this to make the right thing to do, the easiest thing for the clinical team to do, and for patients to also to adopt and follow. So that has been the crux of our work over here. And for today, next slide, please. I'm really excited about our agenda, which is here, and it's a focus on peripheral artery disease, which is a condition that I don't think gets as much attention as to strokes and heart attacks, which are ones that we have been focused on. But again, the impact of peripheral artery disease and the bad health outcomes that can link with that, and in conjunction with that, the functional limitations that patients suffer is not to be minimized. And I think the awareness of this condition and how we optimize diagnosis and management of these. I'm sure we'll learn more from our speakers today. At Palo Alto Medical Foundation, we have teams that focus their work in this space. And we're very excited to kind of learn from national experts today to see their framework and see what we can learn from them as well. So with that, I'd like to turn this over to my co-chair, Dr. Stock, who will introduce our first speaker. Thank you.
Thank you, Ed. Welcome everyone to this episode of the Right Care Initiative, where we are about to have a great treat and by a very distinguished group of vascular innovators, I would call them. They take care of very, very sick patients, in the sense that these patients are often some of the most difficult and challenging. As a non-invasive cardiologist, I, don't normally have to manage these patients, but I do see them, and they become very difficult to manage. This group of surgeons, Dr. Vincent Rowe at the University of Southern California, with Dr. David Armstrong, have been innovating in the field of implementing quality treatments and group efforts to manage these patients. Dr. Vincent Rowe is professor of clinical surgery at the University of Southern California School of Medicine. He has published extensively and has been working as a vascular surgeon for many years. He's been at the University of Southern California since 1999 and has been also an outstanding teacher at the Keck School of Medicine, training surgeons in the skill of revascularization. But not only that, he has gone further to develop models of clinical care and best practices for these patients who are troubled by critical limb ischemia and is not only saving limbs, but also lives. So Dr. Vincent Rowe, why don't you take us through this journey and help us understand how you do it?
All right, thank you. And, thank you for the invitation, first of all, and, generous introduction. I don't know where you found all that information, but I'll take it. I think for today, the biggest part of it was that I am a former Cal Bear. So, go Bears. So that's, yeah, that's kind of the alma mater that I choose out of every place I've been. So I'm just going to briefly take kind of a 10,000-foot view of peripheral arterial disease as we deal with it in vascular surgery. I think Dr. Armstrong will probably come down to about 5,000 feet, and Dr. Arya and our research assistant will probably come down to about right on the ground where the research is right now cooking, and they'll give that input. So for those of you that are familiar with the disease, this may seem a little easy. For those of you that are not, hopefully you gain a better understanding of it. But why don't we go ahead and begin? And I don't have any disclosures. And we'll go through the peripheral arterial disease, kind of comprehend the severity of it, understand some of the research. I'm not going to go so much in the surgical treatments because we're constantly debating what is the right treatment for a patient. And so I don't want to get down into that rabbit hole and kind of stay above and actually talk about some of the medical therapies briefly. And then lastly, what we can do as patients, individuals, and individuals that may be at risk ourselves. Well, peripheral arterial disease affects quite a few people, first of all. I think the 10 million is probably an underestimation that is occurring in our country at this point. Problem is the majority of the patients are asymptomatic, and so they don't know that they have it. But when you look at the high morbidity and mortality rates, you would have to say, why aren't we doing more? What is the initiative to really try to diagnose this earlier and put our screening mechanisms at risk populations? And I think that's just the burning question that has to be sought out within the next couple years. Fortunately for us, peripheral arterial disease occurs in the vessels, but it only occurs in certain parts. If it was to occur in this model here to the right or left, whichever side it is for you, and from here directly all the way down to the knee, there would be very little I could do about it. But the fact that it occurs kind of segmentally here in the neck, there's some here in the aorta, some here in the groin and the iliac vessels, some in the knee, some in the regions down here in the calves. Because the plaque tends to space itself out, then we're able to find treatment methods for it. And perhaps through a bypass or stenting or medical therapy, be able to treat some of these patients and cure them. But it's not very often we're able to do that. The problem is that most of the patients, once they gain and have a diagnosis of peripheral vascular disease, they usually have it in other places. So if they have it in their carotid arteries in the neck, they probably have it in their heart, they probably have it in their legs, and overall their survivals are terrible. And if we just use this picture model here, you can see the 5-year survival for peripheral arterial disease is much worse than some of the other diseases that we commonly feel are big population issues. So PAD seems to be the forgotten module here. We all know about prostate cancer and have great screening mechanisms in place, colorectal cancer, breast cancer, but it's almost like PAD has been the forgotten silent killer of people in our population. And the mortality for what patients usually die from, it's usually from their heart. So although they may only have it in their legs, what oftentimes leads to their demise is heart disease. So it's the same plaque in the legs that may lead to an amputation, or in the neck that may lead to a stroke that is deposited in the heart and leads to their demise, unfortunately. And this is basically another look at the survival rate for those that are finally diagnosed with PAD and those that finally become symptomatic. So you can see once the patients do become symptomatic, we as the physicians finally pick it up. By then we're way too late because the survival rate for that patient at 10 years has dropped about 20%. So that's why if we're going to have these patients survive, we need to catch them early on before they are diagnosed with PAD. And this is what we're looking at. This is kind of our daily patient that we're trying to deal with and trying to avoid from trying to treat these patients very early. Because once they have an amputation, numbers are horrible. And the numbers are almost accelerated. So it's as if you just send the PAD going wild in in kind of a sense, in that you can see that after the patient has an amputation, like I just showed you, almost 50% will die in 1 year, and so on. And you can have these numbers that Dr. Armstrong will go into. 30% have an amputation of their other leg within a year. And so it's a very dramatic disease, especially when they reach the point of needing an amputation. This is what we're trying to do. We're trying to save these patients and get them moving and not end up with amputations. And we don't even really want them here, because what did we accomplish by putting the patients here? Definitely with an amputation, this is oftentimes their resting place until they close their eyes. And we're trying to avoid that. We really want them out, moving back in the community, staying as functional as possible. Anybody remember her? You can put it in the chat if you do. I don't see anything. Ella Fitzgerald, 13 Grammy Awards winner, sold over 40 million albums. She was a bilateral amputee before she passed away. What about this one? Who did this painting? I don't see it in the chat. It's kind of a vascular almost painting, talking about the passage of the vein from here to here, the reflection of herself. I'm not an artist, but they talk about how this was her prior life. This is her current life, her sadness, what changed in her life. Frida Kahlo. And she also was an amputee before her death, suffered gangrene. This gentleman, Jackie Robinson. Jackie Robinson, considered one of the most transformational athletes that we've ever had, was scheduled for an amputation and actually died of a heart attack just before the amputation. He was only 53 years old. One of the greatest athletes, dying from a heart attack at that age and suffering, almost needing an amputation. And lastly, we all know her, Zsa Zsa Gabor. Question is, how many times was she married? Who has that one? She suffered an amputation right over here at our sister institution, UCLA, in her 90s. Oh, okay, no one had, I didn't see that in the chat. 9 times she was married, 7 times divorced, because one marriage was annulled. And then when she died, she was still married, so it wasn't 9 times divorced. So what are the symptoms for these patients? Oftentimes early on, it can be cramping in the leg muscles when they walk, most likely due not to any fatigue, but basically the muscles just don't get enough blood flow and there's a buildup of lactic acid. And so that's why we try to get the patients to walk and walk once they get to this stage, because we can at least build up their muscle conditioning to help them tolerate the lack of blood flow. We're not creating new blood vessels, that kind of happens on its own, but we're really helping them tolerate the lack of blood flow. But if this continues and we're not able to catch the patient at this point, it can get pretty significant. And it can get to the point where they have pain at rest. At rest, their muscles are ischemic and they dangle their legs over the bed, one or both legs. They can start to get ulcers that may not heal, and they can go all the way to very large, dramatic ulcers. These are patients that I actually took care of. I didn't get these off the internet. And then if the tissue is terribly ischemic with a lack of blood flow and there's a bump to the leg or a wrong rubbing from a different shoe, the tissue can just turn gangrenous, and it can get pretty extensive and even more horrific. And finally, the worst one I had ever seen, this poor gentleman, he was only 42 years old. So it can be from very mild symptoms to the most extreme, but either way, it is debilitating. These are the films of what we look at when we talk about this blockage. What does it look like in terms of an angiogram? Here you can see pretty much a normal angiogram of a patient's the aorta, the main blood vessel in the body, coming down, dividing around the belly button to go to both legs. And you can see it looks pretty normal. And this is one obviously that is abnormal. You can see the lack of blood flow through the main vessel here, lots of disease, lots of narrowing here as well. And we see this all the way down. This is another example, terrible disease going down this side of the body. It can be down in the lower extremities. This looks normal. This is abnormal. You can see the area, both sides. This side is not as bad as this one where we have a long segment occlusion. And in the foot, here can get to this. And so it can be rather dramatic for these patients. And this is when we usually have to intervene. At this point, I consider us too late when we're seeing patients with this amount of blockage. What are the risk factors? By far, age is one, occurs more frequently in the elderly population. Unfortunately, I do believe we are seeing younger patients. And if we had time, we could talk about that. But we're starting to see patients as they get younger present with peripheral arterial disease, which is somewhat frightening. You have to wonder what's going on in our society. I think I have a, hopefully it's not us, fire alarm. And this is the prevalence with age. What about, and here you can see as the patients continue to age, the percent that will have peripheral arterial disease is going to increase. And overall, their general conditions are going to increase. So this can be very dramatic for patients. And so therefore, vascular surgeons are going to be more and more needed. Let me just get my headphones here and mute this. I think we'll be okay. It's just some burning popcorn.
I just want to reassure you that we could not hear the noise in the background. So you've got some nice noise canceling technology happening there, Dr. Rowe. And are you sure you're in a safe place with the fire alarm going off?
Yes, yeah, I'm sure. There, but let's keep going then. You still can't hear it?
No, just a little bit, man. You sound great. I mean, you sound like NPR, euphonic, stentorian great.
All right, well, let's keep going. Diabetes. I know Dr. Armstrong is going to focus on how this affects the foot, but it affects a number of other areas. Leading cause of kidney disease, blindness, cardiovascular mortality, terrible disease, and it's hard for people to live with. These are the numbers, though, for younger patients, much more common in our underrepresented minority patients. And they're saying that early on now, as we talked about vascular disease earlier in patients, we're seeing diabetes earlier also. 1 in 5 adolescents between the age of 12 to 18. So if they're already stricken with diabetes at that age, you can imagine what will happen to them probably in their early 30s. We're going to be seeing them most likely for peripheral arterial disease. And this is how the curves are predicted that by 2060, we're going to see a big increase in diabetes. And it's going to be in, again, most likely to have that biggest impact will be, unfortunately, Black females, followed by Black males. But everybody will see this increase. And this will be somewhat interesting, especially as America is changing. You can talk about what's taking place. We're seeing an increase in Hispanic and Black and other races. And so would you see how the whole situation is changing in the United States between 2010 to 2020? The diversity index has changed and increased. mainly through a growth in our Hispanic population, not so much in the Black population, but also in people of mixed race. So we're seeing a lot of different people that may be stricken with this disease based on how we're growing in our United States. And this is just a representation here of what we're seeing in terms of our most diverse states across the country. And if you do somewhat of an overlay with the amputation rates, you can see that some of these areas that are more diverse are the areas that are seeing higher amputation rates, especially in our Southeast. Smoking, by far one of the biggest risk factors. I had a patient today, had an ulceration. I said, you need to stop smoking. He said, no, he's not stopping. And so what do you do? But by far, one of the biggest risk factors that we see. Fortunately, across the country, this is just data that was the latest from the NIH. We're seeing a decrease in smoking in both males and females. So hopefully that will not be as big a factor for us. We're under 20%, at least in the female population, for those under 65. Hypertension, as you mentioned, is a big peripheral issue, affects the vessels. The pressure in the pipes just continues to increase and cause all kinds of problems. By far, most in African Americans, but we're also seeing it across all the board for our patients. So hypertension is always a risk. And this was the prevalence that they talked about. Again, overlay between the Southeast for our diversity as well as our hypertensive groups, and not so much here in the Midwest. Elevated lipids, by far, race and obesity all tie in. I just want to spend a second more on race, though, because we do have to talk about that. Definitely higher prevalence of peripheral vascular disease in patients of underrepresented minorities, especially in African Americans and Hispanics, and we're seeing that. And it's interesting because there were so many theories. When I started as an attending, I heard all of these different theories as to why we were seeing higher and poorer outcomes in African Americans. Referral bias, greater risk of severity of disease. And I think to some extent, they're all true, but it's hard to put a finger exactly on which one it is. I think we've exhausted ourselves trying to figure out which one of these factors could play a bigger role. And I think we need to shift our thinking into, okay, we may not know exactly why, but let's see what we can do. This was one study we did quite a while ago at LAC-USC, and we saw poorer outcomes in the patients that were having a lower extremity bypass that were African American. And by far, they were lower than our other groups. And we still didn't really know why. We tried to explain it, and since then, there's been a number of different researchers that have found similar findings. And so we know PAD, worse outcomes, African Americans, Hispanics are probably followed. Who knows where mixed races will be, but we know by far the African Americans do the worst. What are the issues? I'm not even sure. When we looked at it at LAC-USC, I said, okay, in our study, everybody was not compliant. They were somewhat from the same socioeconomic status. There was no referral bias. I was the surgeon, so I didn't think I was biasing African-American patients. We had a pretty good technique, so it was a single institution, and they all presented with horrible disease. So really, what was it? I mean, I don't know. I think it's just basically being Black, and that kind of hit me in the face. And I had someone that talked to me about it. They said, okay, 58 years old, mom passed away on renal failure, had a few heart attacks, dad also heart issues, sister has some heart issues, cousin has some stents, uncles had heart attack. I said, you're at high risk. You're at high risk. And that was me. And so all of a sudden, I became a risk factor. And that kind of hit me in the face and said, I got to really do something because I'm not going to have an amputation. I'm not going to end up on dialysis. So how are we doing overall? Overall, this was a study we did, and we were really looking at how the treatment had changed. We were looking at the fact that there were less open bypasses and more use of stents and balloons to treat patients with PAD. But what was interesting, we started to see a decrease in amputation rates. And we said, okay, is this real? No one's going to really believe it. And so we looked and we said, okay, this was all amputations coming down quite dramatically over that 10-year period. And we looked at the amputations that were due to PAD. That seemed to be the biggest contributor because infectious amputations came down just slightly. Trauma, malignancy, and all these other causes weren't the driving force. It was mainly PAD. And then we said, well, what age group was benefiting? Young patients, you know, from traumatic injuries or whatever, osteosarcomas, were still losing their legs at the same rate. Same in these younger patients. The main group that was benefiting were those over 75. And we followed that data out, and then diabetes care came out with a similar chart showing that, yes, the below knee amputations and above knee amputations are seeing a decrease. And we are seeing an increase in foot amputations, which I think is good. That shows our podiatrists are getting involved early and saving overall limbs. So this is a very good curve that we're seeing. And we're seeing the decrease in men and women, still though a gender disparity, still a gender disparity. So we need to correct that. Men need to do better. And this is what we saw in terms of our breakdown by race. Improvement in everybody, but the Blacks were still the worst, followed by Hispanics. And that was what was seen all the way out to 2017. Everybody decreased, but still some gaps here between race. This is thanks to Janssen. They were able to look at this very closely and see some of the national viewpoints. And with their work, they're able to dial it down very closely, even down to the state of California, and talk about race where amputations seem to be hotspots here in the Southern California area, up here in Contra Costa County. And I'm not going to get into the details for the lack of time, but we can see that they're able to at least identify these areas. And I think the next big question is, what are we going to do? And if you look at the limb amputation disparity ratios for Black patients, 2 times higher in the county, 1.96 times higher in the state when compared to white patients. And similarly, if you look at the ratio of limb amputation for peripheral arterial disease, very significant here in the Hispanic group, where we're not doing as much peripheral arterial work to save limbs. So this data is there. What are we going to do as the public, as the physicians, as the healthcare professionals to try to get this better? So we talked about the disease. We talked about how we're going to treat. Let's talk about briefly the treatments, and then I'll be closing soon. Open surgery, bypasses, and balloons, stents, other devices are all out there. This trial should have the results. It was a nationally funded multi-center trial looking at the 2 therapies. Patients were randomized between the 2 therapies, and then we're able to see which one is better. The results should be out this fall, and we'll have an idea giving us some guidance on how to treat these patients. In the meantime, controlling diabetes is key by far, lowering lipids, blood pressure control, as we saw, and that's beautiful what the Right Care Initiative is doing. Antiplatelet agents are key for the patients to try to decrease the stickiness that will happen as it passes through those vessels. And these are some of the studies that have documented that. And even now we're seeing better studies in terms of the newer agents that we have. We're seeing benefits to have patients on Xarelto, almost prophylactically or early on in their disease rates. So that is going to be very important, and I think a key in helping to treat these patients. Exercise is key. And what about diet before we close? Well, I know Dr. Esselstyn, he was at Cleveland Clinic and he pretty much got run out of the place, and for saying that a vegan-based diet would help coronary artery disease. But he did have data to show it. This was a patient with a coronary angiogram, and you could see the plaque here in the coronary vessel. 32 months after a plant-based diet, he went back and angioed them again, and you could see the benefit here. Plaque had almost resolved. And I hear this from patients all the time. What do I do? How do I get rid of this if I don't know how to take any meds? Well, I say you'll have to go vegan. That's the only thing I've seen in terms of a natural remedy for this disease. And lastly, is it possible to impact it with lifestyle changes? Well, we just look at the blue zones. These are the zones that they've identified in the United States where people live longer and benefit from this longevity of health. And they looked in to see exactly what they were doing in these areas. In the United States, the only place is Loma Linda, California. Central America has in Costa Rica, Italy, and so forth. And so they looked to see, and these were some of the findings from each one of those blue zones. You can see in Greece, they had the lowest rate of dementia. And in Italy, highest concentration of male centenarians. And Loma Linda, 10 years longer than average people in North America. And this is what they saw in each zone and kind of had an overlap. And just to put it briefly and kind of put it all into one area, you can see these were the things that they said would really help and what was helping these people in these blue zones. Natural movements, just getting up, doing things, and knowing that you have a purpose, trying not to stress so much about everything. This is one I need to do, 80% rule, only eat until you're 80% full. I never know when that is. I always know when I'm 50 and when I'm 100. So that's a hard one. But yes, obviously, they found that it's not necessarily that you had to be vegan, but just more plants as opposed to meat. Some areas enjoy wine and have a strong representative of family and feel like they belong to each other. So I feel this PAD, although it is a significant problem, I do believe we have to move towards early diagnosis. I think screening is one of the things that's important. And again, I think we have to stop talking about the disparity that we're seeing in race and talk about what we can do. That has to be the key. There will be a lot of new therapies, and hopefully we can implement them in the right way and early enough to try to save our patients. And then we do have to take some responsibility ourselves and change some things on our own. So thank you.
What a great presentation. Thank you so much. I just commend you for this magnificent work. I believe Dr. Stock will be introducing your dear colleague, David Armstrong, now. And keep at it to encourage those blue zones activities in your patients and start thinking about public policy fixes that you want us to try to get our government to implement to help with this, okay?
Definitely a big challenge, Hattie, coming our way. And now that Dr. Rowe has set the place on fire, literally, with these statistics and showing us what an incredible challenge we face and how returning possibly to more of the basic styles of living, focusing, on ourselves and our loved ones and our communities might be the way out of this pickle little by little as we start to dig ourselves out. Thank you, Dr. Rowe. That was very enlightening. I am delighted to present Dr. David Armstrong, who is a professor of surgery at the Keck School of Medicine at the University of Southern California and co-director of their limb preservation program, as well as director of the Southwest Academic Limb Salvage Alliance. I love the acronym SALSA. And they have been at the forefront of vascular innovations and leaders in limb preservation to reduce amputations. And I understand that your models have informed global surgeons, and he will discuss with us how incredibly useful it is when you start thinking of these patients in a multidisciplinary approach. And Dr. Armstrong, take us through your presentation, please. Can't wait.
Well, Dr. Stock, thank you very much. And Vincent Lopez Rowe, that was awesome. So let me share my screen and let me see if you can see this. Can you guys see it? Outstanding. Well, ladies and gentlemen, again, thank you for letting us play hooky from a crazy day. It was great having my Flomigo, Vincent Rowe, begin this. And I'm going to kind of take you distal here from the heart all the way down to this anatomic peninsula at the end of the body of the foot. And we're going to try to cover a lot of ground in a relatively short amount of time. We give away all of our slides. I would just invite you to just ping me. I think I sent them to Hattie already, but I'd ask you just to copy them, make them better, and pay it forward. How's that sound? So, you can ping me whenever you like, as you like it. We don't have time to get into this, but this on a completely different, but sort of related note. I'm really fortunate to be the PI of this really cool NSF program. It's called the Center to Stream Healthcare in Place. And the goal of this is to really maximize what we call hospital-free days and activity-rich days. And it's one of these really nifty industry university collaborative research centers. And it is taking off like a shot between our unit and Caltech and UNC, University of North Dakota. We're doing drone stuff with them, and Baylor and U of A. It's really fun. But ping me if you have any questions about that, or maybe we could talk about that at another time. But what we are going to do is we're going to get very specific, and we're going to be talking now. You've heard a lot about from Professor Rowe about the scope of the problem. You're going to hear a little more from me about that, but we're going to talk about limb preservation and diabetes, and really, not to get alliterative, but combining, if not the technology, then at least the team and the tenacity on this chat today. And that's really the big idea. The first thing we're going to talk about, you've heard a little bit of this already, but we're going to get very specific about why this is a big problem and why you should even care about this on, what is it, a Tuesday afternoon. Assuming that we can convince one another that this matters, what we're going to start talking about is putting together teams to try to prevent amputations. We're going to talk a little bit about the toe and people that look after the toe. We're going to talk about people that look after the flow. Then we're going to mash both of those together in the toe and flow model, and we're going to show data to support that. Not only importantly for me, clinical data, but important for everyone else, I think, economic data to support that this helps as you can, since you guys are near to Silicon Valley, scale this up, to overuse that term, which was overused in the early 2000s, I think. So let's get rolling. And so this is what I do. I'm a toe doctor, a foot mechanic, as it were. And, working at the end of the body, I can think of really two great gifts in looking after people's feet. The first is sort of in this era of, chest thumping or chest thumpery and hubris. Is chest thumpery a word? I can't think of anything that's more of an expression of humility than looking after someone's feet. It crosses all borders and, ethnicities. And if you think about it, I mean, even time especially when we're talking about something as, often people consider surgery to be kind of the height of hubris sometimes. But I think the more you do it, the more you err on the side of the humility. And I can't think, when I think of vascular surgeons, I don't know any other surgical specialty that spends more time thinking who not to operate on than who to operate on. Frankly, these are surgical actuaries in many ways. We don't have time to talk about that, but I'm just a fanboy on those women and men all the time. The other great gift, though, in addition to in addition to the humility bit, is this gift of perspective. My dad used to say the best gift you can give anyone besides your love is perspective. And when you work at the end of the body on that peninsula, you can't help but collaborate with the anatomic mainland unless you want to kind of live kind of a professional episode like of Lost, where you're kind of just hanging out there. But I think that, when you choose the latter, when you choose to work with folks on a daily basis, it's easy to talk about on a Zoom and it's hard to do in real life, but just because something's hard doesn't mean it's not fun and doesn't mean it's not worthwhile. And that's really what we're going to be talking about. And speaking of that, this is the first surgery ever caught on video. Check this out. This is Professor von Bergman. I gave a lecture in Potsdam at his institute named after him. And check this out. Look what it is. It is a BK amputation. There he is. That's like a fourth year student. That's going to be like Jenny Wu someday. So look at that. Oh, what? There it goes. And what we see here is that's like the fellow. Who am I? Am I an attending? Am I a resident? Where do I belong? She is clearly the QA nurse. She's upset that he's not wearing gloves, but she's happy. He's happy. She's happy he's turning the room over so fast. But you know, none of that mandatory anesthesia screw around time, you know. But listen, the learning point here is not that the professor did this so quickly, faster than I could say it. It's what's happening to this woman or this man proximally, like that we can't see, like 100 at the head of the bed, 120 something years ago. And that person probably had a better outlook on life in terms of quality of life years ahead of her or him than someone right now, believe it or not, whether it is in Contra Costa County or in San Francisco in the city, in Silicon Valley, in Los Angeles, or wherever, having his or her leg off. And that stinks. And there's a lot we can do as a family. And that's really what we're going to talk about. So let's get on that and do it. I'm going to talk about some of these data and I'm going to race through them because I don't want to bore you more than I'm already boring you. You're already saying, God dang, I can't wait for Dr. Arya. And boy, wasn't Rowe great? That's my purpose, is to be that bridge. But look at this. I don't need to be alliterative here, but these diabetic foot complications, they're common, they're complicated, they're costly. Let's start in the common bit. You already saw bits of this from Dr. Rowe. And give or take 350 million people in the United States, about 10% now have diabetes, and about half have the most generous definition of loss of protective sensation, or I should say of neuropathy or peripheral artery disease. And these do overlap a bit, but what you see here is that people with diabetes can wear a hole in their foot, like you'd wear a hole in a sock or a shoe, and that hole is called an ulcer. It happens every second now around the world, and about half of them get infected, and that's why about 20% of those get hospitalized, is why there's an amputation now every 20 seconds around the world. And we have a lot we can do to make a difference here and make that count. But that's how common here. Let's continue here with complicated. We looked at the World Health Organization global burden of disease, and we didn't believe these data when we first looked at it. But check this out. When you disaggregate, and who doesn't like to disaggregate, right? When you disaggregate feet from the rest of diabetes, what you basically get is a top 10 condition in terms of years lived with disability. It's pretty crazy. And actually the data are worse now than when we first did this in 2018. We've looked at this now a couple of times. And it's pretty crazy. And if we looked at every hospital or outpatient visit as well across the United States for 5 years using CDC data from Shipra Arya's former Atlanta, right near Emory University, where she used to hang out. But check this out. DFIs, diabetic foot infections, diabetic foot ulcers, I think we can safely say in terms of risk for hospitalization and other complications and other complexity like referrals, I think we can safely say based on this histogram that they are at least as complicated as many of these things that we know are complicated, like being on dialysis or having cancer or having diabetes or any of these other complications. This is pretty crazy when you start looking at these data writ large. But let's continue this and let's maybe look at it a slightly different way. You heard this slightly already with Dr. Rowe. It's not fair to compare one horrible thing to another, but let's do that because frankly, on this Zoom call, I don't know how many people really care about feet. Not very many. Maybe a few more care about diabetes, but everyone cares about cancer. We all have had family members that have survived or succumbed or are living with cancer. But let's do this. It's not fair to do this exercise academically, but let's do it. Let's compare them. So check this out. So these are data from what we did. It's already 10 years old, but I left it in because it's conservative, the most conservative data that we have in terms of cost. Now the data are about, believe it or not, almost double this. I know it's hard to believe, but there you are. This is from Neil Barshis and coworkers, and we did this together. And if you look here, lower extremity complications of diabetes are more expensive now than the 5 most expensive cancers in the United States. This is true in Health Canada. It's true in the National Health Service in England. It's extraordinary, really pretty hard to believe. But that's the cost in terms of dollars. But more importantly, what about the cost in terms of like real costs, like mortality? And this is extremely morbid to have lower extremity complications of diabetes. Look at this. We looked at all NCI data here in terms of cancer, but if you have a diabetic foot ulcer, if you have a low-level amputation or a significant vascular disease or a high-level amputation, these problems are at least as bad as a bad form of cancer. And, you know, we would never think of withholding therapy on someone with breast cancer or with lung cancer or pancreatic cancer or colon cancer, but it happens all the time with foot problems and diabetes. We have people say, Ms. Garcia, she has that sore. She's going to get another one. Why don't you just cut her foot off and be done with it? And, you know, for some people, that's probably the best treatment. I believe that, but I believe that's a pretty vanishingly small number when we look at the overall population. And I think the data, bear that out as well. So there you are. Let's continue with all this. So not too long ago, we looked to not only at foot wounds, but their recurrence, even more importantly. And if we're talking from a public health sense, so let me just show you these data with Sickle Bus and my old mentor, Andrew Bolton, and check this out. So with the best available data that we have from this study that we did, from this work, you see, are we really that good after we've healed a wound? And can we really heal anyone? Because at 1 year, 40% of folks are going to develop another ulcer. It's about 2/3 at 3 years and 3/4 at 5 for people that have healed a diabetic foot ulcer. So maybe telling someone that they're healed and checking it off a list and kicking them out of your clinic we talked about hubris over humility. Maybe that is the height of hubris. And maybe we ought to be a little more humble on this. And maybe because this is just like any other non-communicable disease, our goal is to stop these acute on chronic complications and mitigate them if we can't completely eradicate them. And we have to live with them. So recurrence in this population, ladies and gentlemen, is not only common, it's darn near likely. So if the foot in diabetes is a little bit like cancer, and we just talked about it at the most superficial level, we could dig in as much as you want, then maybe when folks are healed, maybe they're not healed, maybe they're in remission. And I would offer that word to you because it really plays. It's true I think it's true in vascular disease, where you see that there are more re-interventions now than there are interventions in a lot of parts of the world. And it plays in wound healing because the goal here may be really to extend ulcer-free days in addition to hospital-free days and activity-rich days in patients in remission. And when you talk to your patient that way, and when you tell them that the chances of them getting another ulcer is darn near 100%, then the conversation changes. And that problem hopefully is not 11th on their 10 most important things to do when they leave your office and clinic when you've so-called healed them. Maybe it's 9th or 8th or whatever. And that's a benefit, and that's a goal, a public health benefit. So we don't have time to talk about that, but I will just say that. What's really cool now is you have entire health systems that are taking this on. This is from the National Health Service in Scotland and the rest of the UK. They've taken this on as well, where now they have remission clinics. You can put people into these sorts of things in addition to people that are low, medium, and high risk as well. Too much to talk about, but we can get into that at some other point. And I don't want to bore you with another histogram. That would be cruel and unusual at nearly 5 p.m. on Pacific time. But I'll just show you this. Look, these are the 3 most common factors associated with recurrence in people in remission. Why don't we, but what is this? There's neuropathy, there's peripheral artery disease, but what's this pre-ulcerative lesion? Well, let's continue with this cancer analogy. So it's a callus. And you see this guy is one of our patients, and you see he has had one piggy that appears to have gone to market, unless there's like a wicked hammer toe that I forgot about. Is a wicked a word on the West Coast? I don't even know. I'm a West Coast person, but somehow I just adopted that. But check this out. You have this this is like a coming event that's casting its shadow before, just this bleeding into callus. So how are you going to describe this in a public health sense? If diabetes is a little like cancer, then maybe these calluses are a little like a breast lump. They're a coming event, or it should start a discussion. And this is the way we describe it to our patients. And that's why it's important to take care of the lowly callus as much as a AAA or something really exotic. And I don't think one is more important than another, although I would say probably a ruptured AAA is probably more acute and important than a callus in the near term. In the long term, maybe we have a discussion. Okay, here we go. Let's hustle and go through all this, because it's objectively true that the wheels are falling off the wagon on this lecture. I'm just sort of talking everywhere. It's floating all over the place, but let's bring this thing home over the next half of this talk and talk about this. This seems to be true, that teams seem to reduce an amputation in almost any way. The good news here is that in almost any way you put these teams together, good things happen. And if people care about this, it seems to help. And these data are compelling. You can go in every inhabited continent and see benefits in these before and after studies. There's a net protective effect in putting these teams together. But maybe in the United States, in other parts of the world, there are ways to put teams together that are better than others. And maybe in regions there are, even though you can probably be kind of agnostic to specialty, you can be evangelical, maybe about skill set. And let's talk now about kind of looking after the toe. And then we're going to talk about looking after the flow. And then we're going to talk about mashing those things up and data to support that. And then we're going to, I think, close blissfully for you. And I guarantee you we will finish on time. So check this out. This appears to be true, that if we look after the foot, that seems to prolong the life of the leg. And there are all kinds of data there. But the trouble is, looking after the leg is different depending on where you are, not only in the United States, but sometimes even just what hospital you roll into. There is a massive zip code lottery in almost any metropolitan statistical area in the United States, even rural areas, and especially in rural areas. We don't have time to dig into this, but we can get into this in inside baseball as much as you want. This is actually from a spectacular, deeply written and reported piece in the State magazine. This is not from a journal. This is from I think it's called the State Journal. It's a South Carolina journal that looked at this in just some counties in Carolina. I direct you to that. If you want it, just ping me and I'll send it to you. But what I'll tell you right now is that if we look, it's not showing up. But what I will show you is what you would normally see. I just peacefully look at this blank screen now. If these are data, they're blank data from Sloan and coworkers from 12 years ago at Duke. And what you find there is that if you saw the patient, if a patient went to a foot doctor along with another member of the diabetes team over the past year, then their relative risk for amputation reduced anywhere from on the low end about 20% to on the high end about 2/3 over a 6-year period. That was an astonishing number. And these data have only now started to become more and more robust. So check this out. These are data looking at foot care before new diabetic foot ulcers. These are data from Tsiwei Tan, who's one of my has a K23 award and has just joined our faculty with Vince Rowe, and I'm his K mentor. But look at this. I mean, looking at about 2 million patients here, digging all the way down to about 15,000 and 300,000 in the active group. And what you see here is that foot care before a diabetic foot ulcer really has dramatic relative risk reduction in major amputation in this patient population. And there are any number of studies now supporting the sort of pivotal place in prevention for looking after the feet. And for our sickest patients, not just our least sick, but our sickest patients, it gets better, not worse. Usually the less you need something, the better it works. Here it seems to be the opposite in terms of taking care of the flow and taking care of the toe. But you see the same sort of thing here. I'm not going to be cruel and unusual and really dig into this, but we can talk about this as much as you want. I'd credit again Tsiwei for these really, really fascinating data, looking at people with CKD stage 5. You see a pretty compelling relative risk reduction over a several year period in this patient population as well. This one also just accepted for publication. And if you look at these data from, again, from CDC, this was looking at all kinds of diabetes care. And, to have something that's cost effective is hard to do, but to have something that is actually cost saving is very unusual in diabetes. And the only couple of things that were cost saving in these data were being on an ACE or an ARB, I think, or getting podiatric or diabetic foot care for being limb preservation. So that's about, we don't have time to talk about this in that much depth, but there was sufficient, I think, depth to dig into later, if you like. That's if you add foot care. What happens if you remove it? Sometimes when people say, I'm leaving, I'm out of here, and this place is going to fall apart, what usually happens when people leave? Things change, but usually the place doesn't fall apart. Usually people rally, and there are changes in culture. I thought that's what would happen down in the late 2000s, in 2007, 2008, when foot care was removed in a few states for our poorest patients and for Medicaid patients. This was in the state of Arizona. It formed kind of unfortunately, a natural experiment. And I'll just show you these data real fast. We thought that what would happen would be there may be a little increase in diabetic foot visits, but then people would go to their primary care doctor, or they'd go to a specialist like a vascular surgeon, or they go to someone and maybe get triaged there. And that is not what happened. And this is true in many states, but this was the first state where we measured this. They went to the ED, and it led to what we call foot and wallet disease. And holy cow. So check this out. There was, with the announcement, this was in 2008 and 2009, when foot care was removed from Medicaid patients, euphemistically called access in Arizona. We saw a 45% increase in hospital admissions for diabetic foot infections. There was a 22% increase in length of stay, 45% increase in charges. And for every $1 that was saved on the front end for removing foot care, it was not just $1.25 or $1.50. It was $44. $44 were spent on taking care of these patients in the emergency department and in the hospitals. This is crazy. And so this ultimately changed policy and whatnot. We don't have time to get into that, but there you have it. But that's the bad news. The good news is, look at these data from, again, Seaway, TAN, and you see here now, when Medicaid was expanded in the early adopter states versus the late adopting states, and you saw a massive improvement in reduction in high-level amputation in amongst high-risk communities like being Hispanic, Latino, or being a Black American. So you look at these data, and of course for Native American patients as well. So, and these data are super consistent and super surprising. There was a 33% reduction in high-level amputation with a very big data set. And check this out, same thing for hospitalization too. So that's what happens when you add a foot care. Sorry to get all wonky on you. We'll get a little more practical here in a bit. So when you add foot care, seems to prolong the life of the extremity. When you remove it, bad things seem to happen. And then when you add it again, good things seem to happen. But now let's dig into looking at the flow, because revascularization not only prolongs the life of the limb, but it also seems to prolong life itself. These are data from my longtime friend, my late friend, Ennio Faglia from Milano. He showed this back then, and these data have been repeated a couple of times. It doesn't matter if you're an endo enthusiast, or if you are an open enthusiast, or if you are bivascular, it doesn't matter. Look at this. There is a net protective effect in terms of mortality by looking after the extremity in this patient population. There's a whole lot of reasons for this, but this is what happens when we add foot care, and then when we add vascular care. But what if you can mash them both together? and maybe make two great tastes taste great together, if that's a thing. Maybe we can add the toe and flow together. This is what has happened. This has become euphemistically known as the toe and flow model. It's becoming popular now at teaching institutions and also not teaching institutions, community hospitals now around the United States. It's super fun to see this happening now. And the way it works is this. You have two surgical specialties on one service, and it's different in every institution. You go based on kind of what is needed in those facilities. Ideally, what you want to have is you want to have a single place where people call, and that single hotline we call a hot foot line. And essentially, when this is rang, this then goes to, if it's on an emergency department or if it's on an inpatient ward, someone has a non-traumatic wound, let's say below the knee in someone with diabetes, then this team is engaged, and then the team descends on the extremity and on the person, and they decide what is dominant. If it is an infection dominant condition, then the toe portion of the team is the primary admitting surgeon. If it is ischemia dominant, then the flow portion of the team is the primary surgeon. But this team is communicating with itself constantly, and all of the triage happens ideally internally. And this is a big relief for emergency departments and hospital internal medicine as well. So I'll just say that, and when it works, it's great. Even when it doesn't work, frankly, it's great. It's a little like pizza. Even if it's like bad, it's like still okay. But is that a thing? So look at this. We looked at this maybe 10 years ago, and you see these data here. I'm not going to get into all this, but what we saw in this study, when you put these teams together, was about a 45% reduction in high level amputation, which was very similar to what you saw in other studies. But what we saw here and what we see at our place in LA for sure is very, very similar. We saw a dramatic change away from reactive and ablative procedures toward more proactive and reconstructive procedures. You heard Dr. Rowe talking about more limb preserving procedures, even like localized ray amputations or low level toe amputations, but also foot reconstructions so that people can hit the ground a little better and move through the world a little bit better and maximize activity richness as well as that. So this was presented at VAM, the Vascular Annual Meeting, a couple of years ago now, by Alyssa Pion, one of our stellar vascular surgery residents. She is just a star. If I didn't mention stellar star. And we looked at data in one center that had a pre-existing single specialty clinic that had been in existence for 50 years before we got there. And then we set up shop right next door to it, and then basically did a natural experiment before and after in this. And we looked at 1,143 procedures. And here's what we saw. We saw, of course, a reduction in high-level amputation. We expected that. We left in all the data from that single specialty clinic that was still running at that time as well, so as not to sort of handicap this, if you will. So all these data include that too. Otherwise, these data would be even more impressive. But I tell you, look at this. There was a 40% reduction in high-level amputations. There were 10 times now more outpatient procedures. And then there was, even with the massive change for outpatient surgery, there was a significant reduction in length of stay. And then also on top of that, check this out. There were 5 times more vascular surgery consultations and 4 times more vascular surgery interventions in this study, and this clinic is not even remotely ideal. We still have to ship people back and forth between county hospitals. So this is just getting started. And you see, even when I mentioned, even when some can be better and bad, it can still be good. And you see, it's great if you just work at it and put energy into that system. So this is from my old one of my old institutions by Naren Patel et al. what you see in the vascular surgery unit at University of Arizona, they looked at what's called hospital contribution margin. When I hear words like contribution margin, I sort of feel like I have to take a shower. I don't even know what that is. It's just, but you see here in the most widgetized sense, if you look at this, adding podiatric surgery into a vascular surgery unit seems to increase that contribution margin, which is, I think, quite positive. And you see this was led not only by Naren Patel, but Weizhou, formerly of Stanford, Shipra Arya's stomping grounds, when she's not on her sabbatical, FYI. So next question is, how do we build? We talked about how to build sort of a clinic and a service. How do you build a program now in a public health sense? And that's the last few minutes we're going to spend together. And we talk not only about one step to success, but 4 steps. And you guys are going to be happy because I've already gone through 1 step already. So there's only 3 steps to go after that. And then we can measure these things in terms of measurable outcomes in terms of a limb preservation program. So we start, by the way, with, let me just tell you, we start with the most acute thing, like acute on chronic complications like that hot foot line, and we go to the least acute, the thing that which would be community-wide screenings. And some of these things you can have, they can start at the same time, but you want to focus on one initially. And this takes years to do, but you can get it going with top down or bottom up or both kind of supports. We've already talked about this, the hot foot line. We don't need to talk about this, but your measurable goals, in addition to some of those other things like contribution margin, can be a length of stay and a high to low amputation ratio, which is a quick and dirty assessment of how you're doing in terms of hopefully you're doing more low level amputations rather than high level amputations. Then when someone is discharged from having their ischemia dominant or their infection dominant or they're mixed, they're both conditions assessed on an inpatient basis, they're discharged to a wound clinic, a tissue loss or wound clinic. And the goal here is to get that wound healed and get them into remission, as we talked about. Again, this is what you can do in this center. And the measurements here are, as we discussed, not only length of stay and high to low, but also time to healing. And you can also talk about rehospitalizations in this patient population as a high quality measure of success. It's one of the key things we're measuring in our, we have a whole awesome program now based on the data I just showed you in that one county hospital where we're now running things. And we have a working group that is pan Los Angeles County now across 10.1 million people in all of our UCLA and USC teaching hospitals. It's an awesome program. And we're starting to develop dashboards to do all this stuff. So once you heal someone, remember, they're not healed, they're in remission. And our goal here is to look after these patients and keep them that way as much as possible, knowing that it's a certainty they're going to develop another wound, but we want them to develop a wound and get in trouble doing something, not doing nothing. That may sound like bad doctoring, but I don't think so. I think it's pretty good doctoring. I want them to get in trouble. And you heard Dr. Rowe kind of intimating that, as he will intimate. So that's the goal here for these remission clinics. And we're also scanning these patients if they've had non-invasive, if they've had an endo or an open procedure to make sure that they're not falling out of their ischemia or their remission in ischemia. And the goals here are robust, but we have these guidelines for dosing activity like we dose a drug in this patient population where we can measure skin temperature and dose their activity, looking for inflammation, just as we dose their insulin by checking their glucose in diabetes. And that's a lot of fun in doing this. We do it not only with the toe and flow team, podiatric and vascular surgery, we add a physical therapy, or if you're British, physiotherapy, and we call it toe flow and go. And so it's a lot of fun to do that as well. We don't have time to talk about these community screening clinics, but we just got a big grant now to do this in Pomona, California, in eastern Los Angeles County and San Bernardino County. And it's super fun now because then we can move people into those other risk categories and those other programs as we talked about. More on that later, maybe in another discussion. So I'm gonna, we don't have time to talk about a stairway to amputation. Just like in vascular disease, just like in plastic surgery, you have kind of a reconstructive plastic surgery ladder Here you have a stairway, but you can go up and down this stairway from diabetes all the way to amputation. But the cool thing here, I won't get into each one of these specifically, but the cool thing is that the toe doctors and the flow doctors on this team, as the atomic minimum on this team, obviously you want to have a lot more people involved here, but as the atomic minimum nationwide, can cover just about everything here, which is pretty great. And then you surround it with the rest of your interdisciplinary limb preservation program. We have dietitians, physical therapists, occupational therapists, and folks that are looking after the prosthetic and orthotics, and a whole host of other folks, including plastics and other folks. But this is the core of that program. And this led to first ever kind of dual issue of 2 flagship journals for vascular and podiatric surgery more than 12 years ago. I was one of the co-editors of that, along with my Flow Amigos, Joe Mills and George Andros. What happened was that ended up leading to what we're doing now, which is we've just developed during the pandemic this kind of not-for-profit that is not designed to be yet another kind of a society, but we found that there wasn't one that was focusing on putting teams together. And so what we really needed was something that was kind of like, I don't know, kind of like a dating app. Is it there? Yes, like a dating app and a marriage counselor for putting people together and keeping them that way professionally, with the patient at the center. And that's what ALPS is, the American Limb Preservation Society. So we got this going, and it is so much fun. It is rocking and rolling now. And it's hard, but it's fun. I'll tell you. And so I'll tell you, if you're interested at all in any of this stuff, I don't know why you would be a glutton for punishment, but certainly ping us there. But Madam Chair, we kind of end where we began. Looking not only at, we're talking about hopefully humility, sort of maybe overpowering hubris in this patient population, because it will do that every time. And I think we have to come at it from that way, but also maybe with perspective. And I will close by request with this. You know, when I was a kid, all the way through university, I played soccer. I played baseball too, but soccer was kind of just getting started in the 70s and 80s. And, you know, I was a goalkeeper all the way through. And, you know, if you're a goalie, it's like the opposite of being a fancy pants, sexy striker. You know, those guys, women and men, they could take 20 shots and miss 19. And they're the hero. They're carrying them off the field. If you're a goalie, you know, the same ratio, you know, you miss one through the wickets and not the same sort of result. You are not the hero. But I thought to myself, well, I love that anyway. And I realized that I kind of found myself going into the same job as a foot doctor in clinic with our toe and flow clinic. And I saw this video and it kind of summed it up for me. So I will share this with you. Check this out. It's hilarious. So oh God. So when I first saw this video, I fell on the ground laughing because I said, man, this is not me really, but it might as well be. I said, that's me, like not in the goal anymore, but like in clinic, right? Looking dumb like usual, showing how lame I am, but somehow still being in position to help and make a save. And I thought immediately of this wonderful quote, not from Denton Cooley, the fancy pants late vascular surgeon, but Mason, or I should say Mason Cooley, the aphorist, about 100 years ago, he said this: if you position yourself well enough, circumstances will do the rest. And I believe that's true. And I believe with a little bit of humility and perspective, I think we can make a difference and help folks move through the world a little better, no matter what their health, no matter what their age, and keep a few more legs and a few more bodies, because I think that's what we all deserve. And ladies and gentlemen, Madam Chair, thank you very much.
Thank you so much, David. And I think we have time for a few questions, if we might just have a little bit of dialogue with the audience. And then if you wouldn't mind, David, going ahead and and introducing Dr. Arya after we've gotten through Q&A. And Evelyn, can you see the Q&A? David, can you see the Q&A?
I can see the Q&A now. Yeah, absolutely. Okay. No question, just a comment that I'm digging Dr. Armstrong's discussion. Well, thank you, Melba. What a glorious name, Melba. My Lord, Melba Hinojosa. It's a pleasure. And thank you, Dr. Rowe. Okay. Oh, David Griffin. Sorry, I don't, as you can tell, I don't have any internal monologue, Hattie.
Well, I have a question for you.
Yes.
While somebody curates the official Q&A, and then I'll
because I'm not
I'll
going to curate anything. I'm just going to go straight. I'm going to just power through that. But go ahead.
It's hard to read. It's hard to read through it. I just, in the Right Care Initiative, we've been working really hard just on these 3 biometrics: hypertension, lipid control, blood sugar control. Just theoretically, if we controlled all 3 of those things perfectly for diabetics, how much do you think it would knock down the need for amputations?
Let me not answer that, but let me ask Shipra Arya, because I don't know that there's anyone more capable or that has more rich data than Dr. Arya to answer that question. I'm happy to do it, but I'm gonna kick it over to, she's here, she's on my left.
Thanks, David. Wonderful talk, by the way, as always.
You have very low standards, Dr. Arya. In my case, in this case.
Not at all. You're so engaging, and the data, it just speaks for itself. So back to Hattie's question, I think those 3 things are hugely important. So we published some data on statins in the PAD population back in 2018. And we showed that, if patients just had PAD, because it is so under-recognized, only 10% of the patients were on high-intensity statins at that time, even though that's what guidelines from ACC and AHA and major societies recommend. But if PAD patients had concordant stroke or coronary artery disease, 40% of them were on high-intensity statins. So, PAD alone is so under-recognized and undertreated that, just by virtue of having other polyvascular disease, they were on the right therapy. But if they just had PAD, only 10% were on the therapy. And the patients who were on high-intensity statins, their amputation risk and mortality risk was, less than half of those who were not on statins.
Is that nuts? I mean, and so best med, so Shipra, if we talk about best medical therapy right now, what's your estimate based on of the nationwide data with which you're so familiar? I mean, I know what my estimate is. But
I think if you look at VQI, which is our vascular quality initiative data, still, patients being discharged on statin and antiplatelet therapy. We've been doing this work continuously, but if you just take out VQI data, we are still only in that 50-60% range nationally. And these are centers that are involved in a quality initiative program.
But Shipra, those patients are already self-selected, aren't
they?
So
exactly. So the patients which are not in a center which actually monitors their quality and is part of something like this, it's even less, probably in the 20-25% range most likely.
I think those and then you get even earlier into the disease, or when someone may never get bypass. And you saw some of those data that Vince was showing, looking at kind of a ratio of bypasses or vascular interventions based on PAD as well, or per amputation, kind of a slick ratio to sort of look at that. And you see that people of color writ large are not getting the care that they need. And that's just interventions, not even, and you could just talk about best medical therapy. I bet you it's double that.
Right. Absolutely. And we had similar findings with glycemic control. Hattie, I think you asked that question. HbA1c greater than 8 versus those who had, at the 6 level, well-controlled diabetes, it was twice the risk of amputation.
So there's a measure that IHA uses called perfect diabetes care, and that's hitting all those 3 targets and more. And I'm just wondering, how important is that to preserving these limbs? And how, if we really drive that, will it significantly change things? I see Dr. Sky has his hand up, and I'd like to hear from Dr. Sky a more important question than my perhaps opinion.
Well, Hattie, you can't say that. So I'm Dr. Sky. I'm a cardiologist out at Travis Air Force Base. Wonderful presentation. So my question is this: if we see such groundbreaking techniques and dual teams that go and save limbs, why is it that the adoption rate is not higher? Is it money? Is it resources? Is it cultural? What's the resistance to doing something that so clearly looks like it works well?
Yeah, the data are, like I said, the data are what they are, and it's just super consistent. And I suppose it may initially be that, but now there really aren't any excuses, because if you look at the most kind of crass, sort of widgetized transactional care, right, per procedure, or whatever you want to call it, RVU based, you can win. I mean, really quite well. With all the downstream revenue. Or if you look at I'm going to assume risk for a population kind of end of things as if you're a policy person or if you're an insurance commissioner. And on that end, the data, we showed some, but the data are quite strong. So it's not that people haven't done it because there's some evil cabal or evil cabal sort of out there trying to stop it. Really, it's just that, specialties kind of come and then they go. And we're so kind of navel gazing and solipsistic in our individual specialties that we don't think about that. But, they respond to disease states, right? And now it looks like with diabetes, the most common reason these patients end up in hospital is not for high blood sugar or an MI or a CVA, it's for their stroke. For their foot. And so you're starting to see now these teams kind of start to develop now. But look, when the two of us were training, I would posit, emergency physicians didn't exist, or at least for me. Hospitalists, hospital internal medicine didn't exist up until the mid 90s, and pain doctors as they are now didn't exist. But it's starting to happen now, where you're starting to see these people that are focusing, if you will, on limb preservation, as it were, as a thing, which is why we sort of started that dating app / marriage counselor organization. That's a great question. By the way, there was another question. I don't want to forget this thing about a U.S. preventative care task force. There's a lot going on now in this area. And we just had a paper in Diabetes Care, I think yesterday, the day before, calling for kind of a HEDIS measure. We're calling it HEDIS pedis for the foot, but it's just to do foot screenings on the front end of things. But there are a lot of initiatives now that are starting there. And so I think Nicholas Ferragasso had that question, and I'm happy to answer that question some more. Nicholas, if you want to just email me or ping me or whatever, happy to do it.
All right, so I think we have answered most questions. Fascinating topic. We could continue for sure. And Dr. Armstrong, I think you were going to introduce Dr. Arya.
Oh, it's my pleasure. Well, you guys can read, so that's for your left brain, and you guys can be impressed objectively. But let me just impress you subjectively. Dr. Arya is just a superb human being. I first met her more than a decade ago now, when she was still in Atlanta, at Emory and at the VA there. She has now transposed herself west, and in doing so, taken a lot of the work and the interest that she had there, and just taking it just up and to an entirely other level. And she has published over the last just even the last 5 or 7 years some of the most important public health pieces in this area that I think are going to help guide therapy now over the next 5 or 10 years. And I'm just so thrilled to see all these data come out constantly. And she clearly gets it in this area. And you already heard from her. She's an associate professor at Stanford, and she's the chief of vascular surgery at the VA Palo Alto, which Wei Zhou, her predecessor, was before she went down to take over vascular surgery at my older place at U of A. But it's a pleasure to introduce her. And she's going to be talking about something very specific with Jenny Wu, which is calcification. And calcium makes everything harder. That's the old joke. But I think you're going to probably see that in a public health sense. And I really look forward to these data. Ladies and gentlemen, Dr. Shipra Arya.
Thank you, David, for that really nice introduction. So, as Vince mentioned, that you guys heard the big 10,000-foot view about PAD, diabetes, and how that impacts limb loss and survival in patients with PAD. I have been interested in figuring out, can we diagnose PAD and develop other risk stratification tools beyond what we've been using for 50 years, which is the ankle brachial index. So this is a smaller project that has been ongoing with other projects but it rejuvenated with the addition of Jenny Wu to my lab, who is your lead pre-med student at Berkeley. And Jenny is going to talk about her systematic review while I give this introduction, and then I'll close up with some pilot data that actually we had gathered from Emory, and we're in the process of publishing. So no disclosures. I am funded by the VA HSR&D as well as the Stanford Cardiovascular Institute, and the opinions expressed here are not of the United States government, as I am obligated to say before any presentation. So as you heard, PAD is the next cardiovascular epidemic. I think 8 to 12 million individuals are affected in the United States, and about 100,000 major amputations happen every year in the US due to peripheral artery disease. And despite the significant morbidity and mortality that it has, it is less emphasized, less systemically evaluated. Risk factor modification in PAD is poor as compared to other atherosclerotic disease processes, as we had discussed in the Q&A, that even guideline concordant care of prescription of statins is much lower in the absence of polyvascular disease in PAD. And since it remains an understudied population, there is a need to think about how do we creatively diagnose patients earlier, and calcification is one way that we have been thinking about it. So the standard of PAD diagnosis and risk stratification is the ankle brachial index, and by extension, toe brachial index. And that essentially means you measure the blood pressure at the foot at either the dorsalis pedis artery, which is here on the dorsum of the foot, or the posterior tibial artery, and then compare it to the brachial artery pressure, and it gives you an index. And if it's less than 0.9, then it's abnormal. And what is also of note is that if it is greater than 1.3, then it's abnormal too. And a lot of data that comes out from population-based studies focuses on the low end of the ABI and not so much on the high end of the ABI, where actually calcification drives non-compressibility of the vessels. And so you may get a normal ABI even though you actually have PAD, presence of PAD, or you may have a completely non-compressible vessel and you inflate the cuff up to 250 and you still are not able to compress that vessel. And that patient population is equally at risk of PAD poor outcomes. I want to talk about TBI a little bit here, because toe brachial index is when you measure the pressure of the toe, and there are some classifications where 0.7 and above is normal, and then less than that is abnormal and could be a diagnosis of PAD as well. So development of PAD, it's predominantly attributed to atherosclerosis, which is of course associated with calcification. And calcification is a bad marker in any sort of atherosclerotic disease process. And PAD is often complicated by medial vessel calcification, especially in the crural or the infrapopliteal below the knee arteries. And the ABIs can then be unreliable due to non-compressibility, as we talked about. And this is particularly true for patient populations that are more prone to developing calcification in their medial vessel wall. So that includes diabetics, chronic kidney disease patients, or end-stage renal disease patients, and patients with advanced age. And as we know, we are facing a silver tsunami, so that advanced age population continues to grow and continues to show up in clinics in need of, PAD care and foot care. This study from the Strong Heart study shows, how mortality is not just elevated at the low end of ABI spectrum, which is to the screen left, but on the screen right, on both graphs, you can see that as ABIs increase more than the normal range or become incompressible, the all-cause mortality and cardiovascular mortality is equally high. So we cannot ignore this patient population where ABIs are artifactually elevated or non-compressible. And so how do we better account for diagnosis and risk stratification of this patient population? Now, there are other diagnostic modalities, like I talked about, the toe brachial index, and conceptually, pedal arteries are not affected by calcification. And therefore, it is thought to be a better measure of PAD, especially in diabetics, CKD patients, and much older patients. But there is data that shows that there's variable sensitivity of TBI in diagnosing PAD in non-compressible vessels, and patients who have had minor amputations or have wounds or have pain associated with toe pressure measurements, you are unable to get accurate TBIs. And up to 20% in some cohort studies have shown that TBIs are also non-compressible in those populations. So they're not an absolute answer for patients where ABIs are unreliable. There are other measures such as walking capacity tests or quality of life questionnaires that have been used to sort of risk stratify PAD patients, but they're skewed with the presence of other musculoskeletal disease, so not as objective. So calcium scoring is a novel concept in PAD identification and prognostication, and it needs to be studied more. But in the coronary literature or the coronary space, calcium scoring has been consistently used actually as a diagnostic and risk stratification tool. So our hope is that maybe we could develop some standards to see if this can be standardized and used much broadly in the PAD population as well. And that's how we sort of began our journey into some of the inquiry that we've done in this space. So I'll introduce Jenny right now. She's the lead pre-med student in the Right Care Initiative and has been truly extraordinary in her research stint, and throughout this COVID pandemic has worked remotely and done a fantastic job doing a systematic review to find studies where PAD patients specifically have an objective arterial calcification measure and not just, subjective measure of whether calcification is present or not, quantifying what are the different measures out there and seeing what is the association of calcification with amputation and mortality. So Jenny, go ahead.
Thank you. So in my systematic review, two investigators, one including myself, we conducted a search. We started with a search strategy with keywords including mesh terms such as variations of peripheral arterial disease and calcification. And we first gathered 1,092 papers across multiple databases and excluded 1,040. And then we went from 52 to 40 to 5 following the PRISMA guidelines. And our exclusion criteria was based on the patient population, trying to make sure that it only included peripheral artery disease patients, and also outcomes in terms of whether it's looking at amputations and or mortality. And with the study design, we mainly included retrospective and prospective observational studies. And lastly, we specifically were looking to identify studies that had a quantifiable measure of calcium and explored the association between calcification and the outcomes of amputations and or mortality. And in these 5 papers, there were 4 calcification scoring systems, and the one on top is based on, they use foot radiographs to evaluate calcification. And this calcium score name is the medial arterial calcification score. And it looked at 5 vascular sites in the foot, and they based their score off of the presence or absence of calcification, the length, whether it's greater than or equal to 1 or 2 centimeters, depending on the location, and if there was typical rail tracking pattern that was consistent with medial arterial calcification. And they also had categories based on the number of positive sites to demonstrate the severity of the calcification. So there are 3 groups there. The remaining 3 papers use CT imaging to identify calcification, and they were all based on the Agatston score, and they looked at different regions as well. And the results came out to show that all of these papers indicated an increased risk of amputations and or mortality. I divided within anatomical region, and so the first 2 papers looked at foot arteries mainly, and they both showed an increased risk of amputations, and one of the papers also showing an increased risk of mortality. The next 2 papers included iliac and femoral popliteal arteries, and they also both showed an increased risk of mortality, and one also with amputations. And lastly, the paper on the bottom showed how in tibial arteries, there is an increased risk of amputations as they evaluated calcification. And in this data section on the table, it shows that those patients with higher levels of calcification, with higher scores, demonstrated increased risk in these 2 outcomes. Next one. And so the conclusions that I've found so far with this systematic review is that there is there's limited literature on this topic and on calcium scoring measures. And there's heterogeneity as well. And so it calls for a need for a universal peripheral calcium diagnostic and or risk stratification tool for these patients, as there is an association for a general increased risk of amputations and or mortality in these patients with higher levels of calcification. And so the next slide is my citations, and now I'll hand it back to Dr. Arya.
Thank you, Jenny. And adding to this growing body of literature, we had done a small pilot study at Emory using similar methodology, where we identified, using our corporate data warehouse, patients with PAD who had CT scans, and we chose to go the Agatston scoring method, much like the coronary artery calcium score. The challenge with CT measures is that in the presence of contrast, it's very hard for us to delineate calcium without some specific, maneuvers to separate the 2. So automated methods don't lend themselves well in CTAs, and a lot of the CT scans don't have non-contrast phase or a series where we can actually see the calcium below the groin fold or the infrainguinal segment. So we ended up with a small study with 50 patients who had these non-contrast CT scans. And our goal was to see, can we measure calcium score, lower extremity calcium score, using the Agatston scoring method, and see the correlation with existing diagnostic modalities like ABI and TBI, and also see if there was an association with the primary outcome of amputation. I have to give credit to Sujin Lee, one of my mentees, who was then a medical student at Emory and now is an integrated resident at Mass General, and Aditi Kashikar, who was also a general surgery resident at Emory and now is completing her residency at University of Texas in Houston. They both did this work, so shout out to them for phenomenal work in carrying this research question forward. So we use the non-contrast CT scans using a reconstruction software called TerraRecon. Plaques were identified with a specific Hounsfield unit density, and area was measured based on the Agatston scoring method. It was segmented into 3 segments: aortoiliac segment, femoral popliteal segment, and tibial segment. So you can see that it's a long arterial tree all the way from the aorta down to the ankle that we are measuring calcium, and it's a time-consuming method to measure calcium at each slice and reconstruct it to measure plaque volume, and then divide it into segments and then see the total calcium score for the extremity. So In this patient population, obviously majority patients were older, high comorbidity burden of hypertension, hyperlipidemia, 38% had diabetes, 14% had CKD or renal failure. Smoking history was present in 2/3 of the population. And we had a split about 3/4 patients with claudication, which is the walking impairment with PAD, and the more advanced stage chronic limb-threatening ischemia was present in about 22% of the patients. Average ABIs and TBIs, as you can see, were on the lower end of the spectrum, as these were all PAD patients. The median calcium score, as you can see, it's skewed towards aortoiliac segment. There's more calcium deposited in this area. But the infrapopliteal score had the largest interquartile range variation from the median, suggesting that the calcification in this segment can vary a lot depending on your comorbidity burden. And about 2/3 of these patients did have a revascularization. And at about 5-year median follow-up, major amputation rate was 24% and all-cause mortality was 42%, showing you the high mortality in this patient population. So if you look at the comparison of ABI and TBI with the calcium score, in the first panel here, this is comparing normal to abnormal ABI categories, and the total calcium as well as the segmental calciums were significantly higher in patients who had abnormal ABIs. And within the ABI categories, the artifactually elevated or high ABI segment greater than 1.3, in that the black bar, which is the infrapopliteal or tibial segment, had the most highest calcium score difference compared to the normal categories, and the similar association was found with TBIs. When we did multivariate modeling to see which factors, if we included calcium score in the model to predict amputation, you can see that the presence of chronic kidney disease and hyperlipidemia as comorbidities were the most predictive. TBIs actually were in the final model, but ABIs were not predictive of amputation. And the infrapopliteal calcium burden had an odds ratio of 8.7, which is very similar to what the Guzman and al. Article Jenny talked about, where the tibial calcium hazard ratio was about 11, odds ratio was 11 in the risk of predicting amputation. So very similar findings here. And if we use, the predictive